Hi, everybody. My name is Linda Paul, and I'm Senior Manager Healthy Development at the American Academy of Pediatrics and one of the partners in the National Training and Technical Assistance Center for Child, Youth, and Family Mental Health. I'm pleased to welcome you to this session today that is creating access through statewide opportunities for school telemental health in Texas. We're so glad you're here. We'll get started in a minute, but I'd like to review a few items before we get going, a few housekeeping things, if you will. We'd like to remind everyone of our commitment to maintaining a safe and accountable space. If you experience issues or need assistance, please reach out to me by sending me a direct message found at the top right-hand corner of your screen. And just to walk you through a few of the tools that are available to use during this session, I'd like to draw your attention to the right-hand side vertical bar that features several icons. If you can't see this bar, it might be that you have the total conference feed open, and so we ask that you close that by clicking the X in the right-hand corner of the event feed box. For the icons, you will see that there is a chat for this session, a Q&A icon, and we ask that you refrain from using the chat because it can be a little distracting, but please use the question and answer icon to include your questions. If you see a question there that somebody's asked that you really hope will be answered, please give a thumbs up to it, and we'll know that that question is of particular interest to the larger audience that is participating. We also, if at any time you need to step away, take a break, debrief, or decompress, please feel free to do so. The conference has a wellness room that's open, and you may enter the wellness room at any time by clicking the wellness room button at the top left side of the event navigation bar. A member of the NTAC team will meet you there. So without further ado, I'm going to introduce our speakers for this session. First, we have Dr. Molly Lopez, who is director of the Texas Institute for Excellence in Mental Health, a licensed clinical psychologist and research associate professor at the University of Texas at Austin, Steve Hicks School of Social Work. Her research interests include mental health services, child and adolescent service systems, and the implementation of evidence-based practices and school-based services. She has led a number of initiatives focused on enhancing the effectiveness of systems that interact with children and youth with mental health challenges and their families. We are also pleased to have Lauren Rosa here with us, who is the Internal Evaluation Project Manager for the Texas Child Mental Health Care Consortium at the University of Texas at Austin. Her research interests include children's mental health, state social service agencies, and organizational improvement. Before this role, Lauren worked at the Texas legislature, serving as the legislative director for her hometown representative. And with that, I'm going to turn it over to Molly and Lauren, and the stage is yours.
All right. Welcome, everyone. We're so glad to have you here with us. We hope that you're going to find this an interesting discussion of some of the exciting things that are happening in our state. So just to kind of get us going, you got to hear our professional bios. We thought as we introduced ourselves, what really may be more interesting to you is to meet our pets. Again, my name is Molly Lopez. I am a part of the evaluation team for this project that we're going to share with you today. And on the left hand side of your screen is my newest pet, our Iggy, Lucy, who joined us about a year ago. I'm going to pass it over for Lauren.
Hi, everybody. It's great to be here. On the right is a picture of my cat. We adopted him from a family friend, and they never named him, so we kept the name Cat, and we like to say that it's short for Cathew. And that's him. We've had him for about 5 years, and I'm going to pass it back to Molly.
All right, so we're going to get started. I'm going to start off and tell you a little bit of background information, and then Lauren's going to step in and share some cool data with you all. All right, so just to kind of frame our discussion today, none of this is going to come as a big surprise to you, but we know that as a country, we are experiencing a real public health challenge around children's mental health. And it really has been a growing challenge over multiple years. We see from data that children's feelings of sadness, thoughts of suicide, and even suicide behaviors have been increasing over the last 10 years. And we're seeing that it's really becoming quite prominent in our children and youth. And this particular data comes from the Youth Risk Behavior Scale, which is a nice indicator about how things are changing over time. We also know that it is very, very challenging for many of our children to get access to high quality treatment. And the majority of children with serious mental health conditions don't receive adequate treatment. And there are structural, financial, personal barriers all in place to accessing those high quality services. And as system of care communities, that's about kind of what we're trying to fix, right? We're trying to make sure we can knock down some of those barriers to high quality treatment. We also know, of course, that the pandemic had significant impacts on this challenge, and we hear it from our healthcare systems, from our schools, from our families, that there is an ongoing impact of the pandemic that has just further exacerbated both the public health challenges and the disparities that were in existence before, but have continued to be highlighted by the impact of the pandemic. So how do we think about Texas? Just to give you all a little bit of Texas flavor to this. I always like to just start off with just kind of saying Texas is big. We've got that saying, everything's bigger in Texas, but there really is some truth to just how monumental public health challenges are in a state the size of Texas. So Texas is the second most populous state. It's behind California. We have over 30 million people in the census. And Texas is growing. It has actually had the largest growth of any state in 2023. And there are many regions of Texas that will just speak to the incredible growth that's happening right now. I was talking to a principal or superintendent, of a district in Texas, and he talked about buying portables or ordering portable buildings for 5 years in advance because the growth is so outpacing their ability to get portable buildings in to grow the school with the way that the community is growing. So it's really pretty monumental in many areas of the state. And we also are large geographically. So we're the largest state within the contiguous US and second only to Alaska in size. So big population, big distance, lots of challenges. We also have the highest uninsured rate for children in the US with 10.9%. We are a Medicaid non-expansion state. And we also have very high health professional shortage areas, both in terms of public health, physical health, but also mental health professional shortage areas. So you'll see there that most of our counties are designated that way, and where we have no shortage area are usually just a few of our more urban regions. And our school system, because we're going to talk primarily about schools today, our school system is also very large, of course. We have 5.9 million children across the state covered by public schools and charter schools. And we have over 9,500 campuses. So anything that we think about in terms of implementing in schools is a very large scale implementation. And like many states, our schools are very locally controlled, with responsibility being designated within local school boards, and without a lot of state levers for leading to change. So a little bit more about kind of the school part of our state, a little bit more context. We have had a lot of interest and growth around mental health in schools over the last 5, 6, 7 years. And the impetus for that, kind of the start of the story in terms of school mental health, was a hurricane that hit Texas, Hurricane Harvey, which hit in August of 2017. And it was pretty big in national news at the time, but we had some pretty devastating floods across most of the coast of Texas, all the way from the Louisiana border down to South Texas, experienced significant damage as a result of Hurricane Harvey. And that was kind of an impetus within our state for coming together at a state system level to talk about how do we really improve our access to mental health services, our response to trauma, and our ability of students to get back in the classroom and ready to learn. And from that initial kind of tragedy came a real interest in building some policies and support for school mental health. So what I have up here is actually a few data statistics. I'm going to flip in time a little bit, and sorry for not fully following the timeline, but this is a survey that was done at the end of 2022 of our school mental health districts to understand what is in place in terms of comprehensive school mental health. And so what our schools have told us is about 29% of districts report that they've got strong referral pathways in place, that they've really started to map out how they identify students with mental health challenges and get them to appropriate services through that referral pathway. We found out that about 34%, so about 1/3 of our districts, feel like they have created some formal partnerships with mental health providers in order to either provide school-based services or to make very strong referrals into community-based services. And we also found that about 1 in 5 felt that they had made some significant progress in creating school mental health teams, and teams that can both work to make sure that children are getting the appropriate services that they might need, but also to create some of those system structures to understand where are we seeing the most need and how do we create supports to meet those unmet needs for students, and how do we track the outcomes of our students. So that's kind of what the system was looking like a couple of years ago, which actually was after some of the legislation that I'm going to turn to and talk about now. So I mentioned Hurricane Harvey, and sort of the follow-up to that was a lot of interest in how we build some structures for school mental health. And so in 2019, we had some really significant legislation that happened. And it's Senate Bill 11, and what it focused on, I'll cough for just a second. Apologies. One of the things that it asked is for our state education agency to develop a state plan for student mental health. And in that plan, they asked the state to set some goals to increase access to both school and community mental health services for students. as well as to develop some common school climate measures and to begin measuring school climate and culture. It also required the state to develop a state and regional inventory of mental health resources, so to map out where some of those resources were at both the state and the local level. And it required our local education agencies to develop grief and trauma-informed policies and practices, again, with a real focus on how do we help those students who were impacted by Hurricane Harvey, but recognizing that grief and trauma was a larger concern even beyond those communities. In addition, in that same legislation, legislators sought to leverage the expertise and the capacity of our health-related institutions, so our medical schools in the state, to say, how can we start to address some of the really critical mental health challenges that the state is experiencing? And how can we use those health-related institutions to improve the mental health care system, especially as it relates to children and adolescents? And they also sought to enhance the state's ability to address those mental health care needs through a collaboration, a coordination between all of those health-related institutions. And that was the birth of the Texas Child Mental Health Care Consortium that we're going to talk a little bit more about today. So that consortium is that collaboration of all of our 12 health-related institutions in the state, as well as some other partners. Here is the vision that they created as a part of their work. So the vision is that all Texas children and adolescents will have the best mental health outcomes possible. And the mission is to advance mental health care quality and access for all Texas children and adolescents through interinstitutional collaboration, leveraging of expertise, and locals of both the higher education, but also local and state government agencies and local and state mental health organizations. And one of the things I want to point out in that mission is a recognition that this thing that was created in 2019 through this legislation was really a component of a broader system of care. And so recognized from the beginning in this mission statement is that this particular group and project, probably not the right word, but was a part of the system and needed to collaborate with those other parts of the system in order to make it effective. And we know that in the system of care world, we can't do it without having those partnerships and being able to support children and families in navigating between the different resources that are available for them. So what is in the Texas Child Mental Health Care Consortium? What are the programs? So when I say a public health approach, we are recognizing that there are a wide variety of issues and challenges that we need to address. And this particular initiative is striving to address some of those most critical ones. So the first program up there is the Child Psychiatry Access Network, which we call CPAN. And you may have a access network in your state as well. Many states do. And the goal of CPAN is to provide primary care providers with access to psychiatry and other mental health consultation that is readily available to aid them in providing mental health care within a primary care setting. We expanded that program recently to also provide perinatal consultation to OBGYNs and other physicians as well to help support the mental health of mothers. The third program on there is TCHATT, the Texas Child Health Access through Telemedicine service, and that's what we're going to talk about most today. TCHATT is, as you might tell, it's about providing telemedicine and telemental health in school systems. Next, we have the Child Psychiatry Workforce Expansion, and that initiative recognized that we have a significant gap in terms of child and adolescent psychiatrists, as probably most of the states across the U.S. do. Texas does as well. And so how do we continue to grow our capacity within our health-related institutions to train additional child and adolescent psychiatrists and provide them not only with good training, but also with opportunities to work in our public systems and to get experience in that way. And then we also have the Child and Adolescent Psychiatry fellowships. So not only do we want to provide a workforce expansion, we want to allow for the opportunity for more fellows to work within our state and within our state systems. And then lastly, we have a mental health research area in which the state is doing some targeted research around trauma and trauma-informed care, as well as around depression and suicide care. So that's the broad overview. What were we trying to do in terms of mental health gaps? Really, the mental health gaps can be kind of thought about in three different buckets. So in the first bucket on the left-hand side is our specialty care services, right? So our psychiatry, our psychology, our mental health specialists. So across these programs, we're trying to enhance that child and adolescent psychiatry workforce, increasing the number of training slots, increasing the opportunity for training supervision, etc. We're also trying to provide those training experiences in community mental health settings with the goal of exposing trainees to those environments, learning about the benefits of working in public mental health settings, and hopefully increasing the number of folks who go into those settings following graduation. We also, with some of the federal funds, expanded to additional mental health professionals to try and increase training opportunities for psychologists and social workers and professional counselors, etc. So our second bucket is really around primary care. And here we aimed to increase the training that's available to primary care around children's mental health, increase access to direct consultation, and then provide training and direct consultation around maternal care as well. Excuse me. And then our last bucket is focused around our school system, which is another primary place where children receive care. Here the aim was to provide early intervention that was accessible to all Texas students, to provide an opportunity for assessment to further understand what may be some of the barriers and challenges that students are experiencing, to provide an opportunity for brief solution-focused therapy through telehealth, and then also to support care coordination and referral support for those students that are identified to need some additional services, either in the school or in the community. How do we provide those warm referral processes to support families in navigating the system? So we're going to focus in. That's a lot of the big picture because I do think it's helpful to know that broader context of the Texas Child Mental Health Care Consortium. But we're going to turn around and focus the rest of our conversation on this piece of it. What does it look like to create a telehealth program that aims to provide services in schools across the state the size of Texas? All right, so we call this part of our system TCHATT, the Texas Child Health Access Through Telemedicine, and it has several components to it. The primary aim is to provide those in-school behavioral telehealth care to those students who've been identified as at risk. So it is a school-based service with the goal of providing direct either telepsychiatry or counseling to students in schools. We also, as a part of the process, provide educational and training materials for school staff, both to support systems development, but also to support their ability to identify students with mental health needs and to help navigate conversations with parents about the availability of services as well as to provide some supports around how they can increasingly support students within the school system as well. And then the third component is a statewide data management system that helps with those processes, as well as to help support our program evaluation and ongoing quality improvement, which is where Lauren and I really play the primary role in TCHATT. All right, so a little bit of the timeline. So you heard in the beginning, I mentioned in September of 2019 was when our legislation was passed. And so it was passed in August, and September is when it went into effect. And so that was kind of when everything was authorized for the consortium. We began, of course, rapidly planning for what that would look like. And as a part of the legislation, there was required that we submit a plan to our legislative budget board, and then that budget board could approve that plan, including the budget and how those funds would be spent. Soon after that, after everything got approved, the work to develop agreements and ensure that that funding was moving forward to our health-related institutions, that happened in February of 2020. And in March, all of those funding transfers were completed. So you all know what happened in March 2020, right? That's the point at which COVID happened. So everything was set up. People had their funding in place, ready to get going to provide services in schools, and all the kids were no longer in the schools. So it became, of course, about the worst possible timing there was. But everybody quickly reorganized to figure out how do we do this work and still offer the opportunity up to families through schools, but who are in their homes. And so that was kind of a quick turnaround that we did. And in May, the first child was referred to TCHATT. Over time, what we've been focused on has been the growth of the number of schools in which we are partnering. But it started in May 2020, where we served the first schools. In 2021, just so you kind of understand a part of the timeline, was when we were able to start recording some of that data in that data system. Prior to that, folks were keeping those records locally and capturing things within their EHR and with other tools that they had developed. And the one other piece that's probably important to understand in the broader timeline and context is in the summer of 2022, we had the opportunity to use some of the federal ARPA funds to continue to expand and grow the number and type of services that were being delivered. So we'll kind of talk along the way about where some of those ARPA funds were used after 2022. Okay, so some of the things that TCHATT aims to do, one is to really build upon the expertise that our health-related institutions, our medical schools have, recognizing that they have great expertise in training of the workforce, in providing evidence-based care. And so how can we build upon those strengths in developing this system? It was very important both to our legislature and then to the consortium as we implemented to make sure that parents and caregivers were very involved and were affirmatively consenting to having any involvement in TCHATT from the very beginning. So processes are in place for the schools to ensure that they have parental consent prior to sending a referral into TCHATT. And then there's a secondary consent process as well for the health-related institutions to get consent from caregivers about their student being involved in the services. Services are fully offered for free. There is no charge to families at all, regardless of insurance status. And the idea is to address behavioral health needs early and try and identify those students before those issues become significant. Again, services are intended to be provided in Texas public schools, which includes our traditional public schools. We also have a public charter school system that is a part of our overall public school system. And we had a goal of giving every Texas school district the opportunity for services. It is a choice. They can decline, but every school is given the opportunity to offer these free services for their families. And we depend, of course, on technology, both, of course, at the HRI level, but then also in the school system, to have setting them up with technology so they can be successful around the telemedicine element. And a real focus, kind of recognizing that some of the greatest disparities are in our small and rural districts, districts that may have 100 students across the entire district, one school. It can be many, many miles to drive to the nearest mental health provider. So really wanting to be sure that we are offering this access in those small and rural schools. All right, here's a little bit about the process, just so you know kind of overall what it takes to enroll a school. To start off, the HRIs will engage with that district and work to get an MOU, a Memorandum of Understanding, signed with the school district and the health-related institution around this provision of services in schools. Usually there's things to work out about background checks of providers and things like that in those MOUs. And then the HRI works to onboard the school. There are identified district leads as well as school leads, and they are set up within the data system. There's a portal for them to submit referrals for families. They also have the opportunity to see in aggregate what has happened with the families that they've submitted referrals. No details are shared, no PHI, but they are able to see over time if 75% of the students that they referred went on to get TCHATT services. And then we move on to the service provision area, and the school staff then can start entering those referrals for students once they have parent consent. Again, a few of the kind of qualities that are important in TCHATT as we have designed the program. One is, again, that it's an early intervention program. So when there are referrals for really high acuity or intense needs, rather than having that family go through a few brief telehealth services and then refer on, the HRIs will try to refer and make those connections quickly so that those families are able to access longer term care in the community. It's also important that we, let me step back for a second. I said I was going to highlight some of the ARPA funds. So one of the ways that we used ARPA funds within this model, which is intended to be about 5 sessions, is to be able to offer some extended services in certain circumstances. So some of the ways that we've worked on extending those services is for students with anxiety. There's an opportunity to kind of step up from those basic services into more intense and longer term services. Not long term, but a longer term anxiety treatment. Also with trauma and with substance use, because those were some of the gaps in which we found that HRIs were challenged to find community-based services that could meet families' needs. So some of those funds have helped to extend the amount of time that families can get access to the TCHATT services. We've also focused a lot on measurement-based care. So our HRIs gather symptom-specific measures consistently across all of the HRIs. And then every HRI is measuring functioning using the Columbia Improvement Scale so that we've got a consistent functional measure across all sites. Evidence-based practices is an important part of the model, and HRIs and the staff that they've involved have provided training and received training to help improve their own service delivery. And then care coordination is an important part as well. And all of the HRIs play a role in helping to connect families to services after the end of those 5 sessions, if that's what's needed and what the family wants. And those services could be back in the school. where the HRIs are helping the schools understand what would be helpful to continue to support the student, or in the community, or possibly both. All right, so that is the big backdrop of TCHATT and what's going on there. And I'm going to pass it over to Lauren to share a little bit about our evaluation.
Awesome. Thanks, Molly. Yeah, you can go ahead and go to the next slide. Yeah, so this is a map that gives a kind of geographic representation of the coverage of TCHATT services as of February 2024. So each of the colors represents a different health-related institution. So as an example, to the west, we have UT Health Science Center, El Paso. So that's kind of covers that geographic area. And that health-related institution is then in charge of enrolling campuses and school districts into the TCHATT program. So as of February 2024, there was 5,891 active campuses across 739 different school districts. And each month we collect updates on school enrollment from the HRIs. So this is things like whether or not new school districts are enrolled, whether new schools became active or new school districts were in the process of signing an MOU, and things like that. So that's kind of a big picture look at the state and kind of what our coverage looks like. Molly, you can go to the next slide. Great. Yeah, so in addition to keeping track of schools and school districts enrolled, we also look at the number of student lives that are covered by TCHATT services by comparing the state census data to the TCHATT enrollment status of the schools. So as of February 2024, there were nearly 4 million students at Texas public schools who are able to utilize TCHATT services at their school. And compared to the census has about a little bit over 5 million students at those schools. So we're at about 4/5 of Texas public schools coverage, which is great. And Molly, you can go to the next slide. Yeah, so as you can see, as student coverage went up over the past few years, so did the number of referrals that we were receiving. So this varies across the school schedule, as you can kind of see. So as school begins in August and September and October, we kind of get those that uptick in referrals. And as you get closer to December and into January, it kind of starts to go down, with that winter holidays. In April and May, we also kind of see a lull because of state testing within the state. So you can kind of see that pattern throughout the past couple of years in the referral data. Great. So now we'll take a look at reasons for referral and referrals by school level. So TCHATT actually updated their reasons for referral in October 2021. So the data on this slide is all of the data from October 2021 to March 2024. And the main reasons for referral have been anxiety, depression, and anger. And when students are entered into our data system with a reason for referral, they are also allowed to have multiple reasons for referral. So there is some overlap between these different reasons that are on this graph. And on the right, you can see referrals by school level. They're relatively evenly distributed between 30 to 35% coming from elementary schools, secondary or middle schools, and intermediate or high schools, respectively. And the other 3% of schools accept non-traditional grade levels. So this would be a combined elementary, middle school, or accept something like 1st to 10th grade. Is kind of what that other percentage is. So as of March 2024, TCHATT's provided over 160,000 sessions to over 35,000 Texas students. TCHATT students are typically offered between 4 and 6 sessions with a TCHATT provider before being referred to a community provider, which I'll talk a little bit more about later. So a community provider would be a primary care physician, a psychiatrist, or a therapist if they need some continued care. This has some variability across the different HRIs given the different healthcare landscapes. And as Molly mentioned, with ARPA funds, we've been able to extend sessions for certain cases as well. And it also will depend on the acuteness of the reasons for referral and the different landscape, as I mentioned. And about 10% of sessions involve medication management. Great. So this is kind of the types of support that TCHATT is able to offer. As I mentioned, students are typically offered between 4 and 6 sessions with the TCHATT provider, with nearly 30% of students having over 5 encounters with TCHATT providers and staff. And the types of services you can see on the right are what the students are being offered. The majority of students are receiving assessments and supportive therapy. However, TCHATT offers a variety of services to its students, from family therapy to case management and cognitive behavioral therapy. And the types of services that are able to be offered differ across the different HRIs, with certain HRIs having the capacity and availability of providers to offer things like substance use therapy and play-based therapy, whereas all the HRIs are able to provide assessments and supportive therapy. Yeah, so as I mentioned earlier, when students have completed TCHATT services and completed those between 4 and 6 sessions, they're then referred to providers within their community if they still need to access services. So about half of TCHATT students are referred to individual therapy or psychiatry services, of the half that are referred after services. And another 16% are referred to other types of therapy or other types of providers within their community to ensure that they kind of have that continued care. Great. And so after services conclude, surveys are sent to both the student and to their parent or guardian to ask for feedback on staff, services, and their overall experience with the program. So this has really given us a lot of insight into kind of like the students' and parents' perspective of how TCHATT works. So the HRIs send a short survey to parents and students that are 11 or older, to their email or to their phone number to kind of seek their feedback. And responses to this survey have been very positive from both students and caregivers, with the majority of parents saying that their child is doing a little or a lot better after TCHATT services. And there's a nice quote there where a parent says, "I'm so grateful for this program. My daughter was in a really rough place, and this program was like a shining light to her." So I think that just speaks to, the effectiveness of the program and how a lot of students and families are really happy with the TCHATT services. And I'll pass it back to Molly.
Yeah, thank you, Lauren. Just to kind of close us out before our question and answer time period, just a few kind of last thoughts about some of the lessons learned and some of the challenges and opportunities that have come through this. One is just recognizing that this is a challenging time for schools. We, of course, as you saw, really started to implement this fully right about the time that COVID hit. And so it has been a challenging time for schools in terms of just the many different priorities that they've had, public health things they've had to put in place, staffing shortages that they've experienced. All of those different things have really added some additional challenges to this, but it's also provided some momentum, I think, because schools have also recognized the importance of addressing mental health needs of students as well. Workforce has been a challenge, right? It's been a challenge across the country, so we're not unique in that. But even having the state funding to expand statewide doesn't always mean that we have the workforce available to be able to do it. And of course, we always want to be cognizant of sometimes when you bring a workforce over for a new project, you may be taking them away from community mental health systems, from school systems, right? And so balancing that is an important challenge. Recognizing that mental health can sometimes be a concern to parents or community members or school systems, trying to proactively respond to things that might be a concern, for example, ensuring that the consent process was very standardized across all of the health-related institutions. So there could never be a concern that information was being shared or students were being involved without full parental involvement was important. It's been really a challenge and an opportunity to manage the growth and think about how to create efficiencies. So there have been times where there has been probably more staffing than was needed as the programs were growing, and trying to figure out how do we use folks in the best possible way while we're building this referral pipeline. And then also times when things have been really, really busy, and trying to figure out how to create some of those efficiencies. For example, if one HRI is really, really challenged with the number of referrals that they are seeing, but another HRI has some capacity, how do we help support getting families access quickly by using this broader system that we have in place? There's been a real opportunity and lesson around balancing the standardization across all of the HRIs, as well as their flexibility. So recognizing that they operate differently as medical schools and as departments of psychiatry, and their communities are different, right? The communities in which they're trying to serve have different cultures, some are more rural, some are more urban, and really figuring out how do we create both standardization, but also flexibility. And then linkages with school and community-based services has been an important opportunity. And I think there's a lot of discussion happening, and great discussion around continuing to build those school mental health systems, strengthening our schools and their capacity to recognize and create referral pathways and connect students, but also building on those community-based services as well, so that we can strengthen where our students might get further services. I mentioned earlier we're looking a little bit at tiered services and the opportunity to continue, if needed, with some additional longer term, I don't mean long term, but 12, 15 sessions if needed for particular students, both either because of what the students need and what the HRIs can offer, or because there's a lack of capacity within those communities. And then the final thing I'll say is we've had some opportunity as well through our ARPA funds to be able to have the HRIs get involved in providing Youth Aware of Mental Health, or YAM, which is an evidence-based mental health literacy training for students. It's provided to 8th through 12th grade, I believe. And it's a multi-session mental health literacy, wonderful training for students to both help them recognize and work with their peers, recognize in their own life if they're having challenges, and make some of those referrals. All right, so that was kind of what we had to share. And I'm going to pause and let's see what questions we have. I'm going to leave this up for a second, although I think you can access our slides in the portal as well. But then I'll close it down so we can actually not have a screen in front of us.
Great. Thank you so much, Molly and Lauren, for a wonderful presentation. I don't see any questions and answers in the chat, but I'm going to start it off. Looking through your slides, I think there came, I can't remember which slide in particular it was, but things dropped during the summer months. And so I was wondering what happens during summer months.
Sure. Lauren, feel free to chime in too. So what tends to drop in the summer months is our referrals, because our school counselors, our educators, the folks who are kind of identifying those students are not always at work to do that, and our students are off. We do continue to provide services throughout that time period. So students will be seen through telehealth at home or at school if the school is still open. And then the teams really focus a lot on enrolling districts and providing training opportunities. So one of the things that's really increased their relationship with the schools and provides a strong opportunity for kind of building that collaboration is to be a part of the professional development, the PD that schools do. And they frequently focus in on that kind of at the end of school as students leave, and then importantly at the beginning of school as teachers are coming back. And so they've really focused a lot on providing some of that professional development.
Great. And then I was thinking about, and I'm going to finish this question and then get to the one in the chat. Thinking about, is there feedback collected from the HRI about their experiences, you know, and how they view the program?
Yeah, that's a great question. So we have gathered some data on that. We have gathered information from each of our health-related organizations around the supports that they're receiving. We have a number of kind of infrastructure things in place to make sure that our teams feel like they've got support from the data system to navigating policies and procedures to even just the organizational infrastructure that's in place to make sure all of the HRIs have an equal voice in how the system is developed. So we've gathered a lot of data, or a fair amount of data on are those things working? Where are there opportunities to strengthen and improve? And try to kind of use that as a continuous quality improvement opportunity. We haven't gathered a lot of data from the providers around their service delivery, how they see the service delivery going. A couple of things. One is we do an annual summit. So we bring all of the TCHATT providers together during the summer to have discussions similar, like how do we improve? How do we keep growing? Where are there opportunities to learn from each other across the system and do some of that peer-to-peer learning? So that's another strategy that we've used. And we're getting ready to do one of the things that has been of interest is kind of recognizing that some of our schools have programs that start in pre-K. And we're getting ready to do a survey of providers to understand what they feel like their level of competency is around early childhood mental health. Do they feel like they can provide consultation to families, to school teachers, to the carers for those younger children as a part of this system? And if not, how we might build their competencies and skills to make sure that we are addressing that early childhood opportunity as well.
Great.
Yeah, I can jump in as well really quickly. I will say also, as we're considering any types of programmatic changes, we do talk to the HRIs, and I've actually interviewed some of the different employees at the HRIs, asking about how processes are going, if there's anything that could be improved on the data side, or just in seeing patients, right? So there's definitely a good line of communication between the HRIs and the UT Systems team and our team as an internal eval. Yeah, we're very open door, so I think that really helps when it comes to planning programming.
Great. And the question in the chat relates to ensuring access to affirming care for youth who are trans or gender nonconforming. Can you speak to that in any way?
Sure. And it's a great question and an important question. we are a state that has some of those challenges, just to be honest with you. I think that the things that we have focused on is how do we ensure that the providers that are working within our system are providing affirming care as they are working with students who may be experiencing challenges within their school system, right? That are helping to contribute to some of the stress that they may be under. And how are we ensuring that we have resources if it's going to be helpful to students to access community-based supports, community-based services? How do we ensure that we have all of those opportunities that are going to be really strong connections for our students, both in the school, but then also in our community as well?
Great. So with that in mind, I think we need to wrap up the session. I thank you both for such a wonderful presentation. I know I learned a lot. And thank you for those of you who have attended and for being here. Our next session starts in 30 minutes. We'll hear from keynote speaker, Dr. Tanisha Foster Freeman, who will be talking about individual, interpersonal, and organizational factors contributing to mental health disparities among Black and Brown youth and young adults. So we hope that you will attend that. There are also lightning talks, other organizational rooms to go to and visit. And then, of course, lastly, I'm going to make a plug for completing the survey that goes along with this talk. You can find the survey either among the documents provided for this talk, or the last icon on the tools bar. And please note, that helps with allowing for CEU activities. And so we ask that you complete that. And with that, I think we will close out the session. And I thank you so much again for attending. Take care.
Thanks, everyone.
Thank you.